the United States, here in Melbourne, Florida. We're about 45 minutes from Orlando Airport at Duke Spine Institute, located in Central Florida on the Space Coast. The Space Coast of Florida is known for its space program, which are the satellite launches and the space shuttle launches. With the space shuttle, that program that lasted about 32 years. And we're very close to a place called Kennedy Space Center, named after John F. Kennedy, the president who passed the legislation that basically funded NASA and really started getting the United States into the space race. Okay, so Duke Spine Institute is a lot like NASA in that we're state of the art and on the cutting edge, space age technology we call it, for spine surgery. So it's very appropriate that we're located here on the Space Coast of the United States. For those of you who don't know, our zip code is 321, sorry, not zip code, our area code for our telephone numbers. 321 because 321 launch, right? So the Space Coast of Florida was given the telephone area code of 321 to commemorate and symbolize the fact that we launch rockets here. And that's always the last thing you hear before a rocket goes up or a shuttle goes up is 321. Many people don't know that I've been here in the Space Coast for many years, even before I started my practice here. I was on the NASA Space Shuttle medical team, and our purpose was to protect the astronauts from being injured or hurt during a problem with the shuttle, for example, with the launch or landing. All right, Dr. Duke here. We're going to get started, okay? I need you to do a few things. Number one, I want you to lay still and not move. Can you do that for me?
Yeah, as long as you don't start poking me with big objects.
So lay still. We're going to put you to sleep as soon as we can. And if you're having any discomfort, just say ouch, and then we're going to ask you what's wrong, and you just tell us, okay?
All right.
Sound good?
Yeah.
All right. Any? Yes, I'll talk to you and let you know what's happening, okay?
All right.
The first thing I have to do is numb you up. Now, our patient has 3 herniated discs, L34, L45, L5S1. L34 happens to be on both sides, and he does have pain up at the L34 level, so we're going to treat L34 bilaterally, and then we're going to treat L45. We have those up on the left side at 4.5, on the right side at 5.1. Everybody in agreement? All right, so I am. Is he too warm, or are you happy with his body temperature?
Happy.
Okay, good. Yeah, I feel him. So I just kept the room temperature where it is. We didn't cool it, and I'm fine with it being a little warm as long as you're happy with his core temperature.
Thank you, doctor.
Yeah.
You can actually bring it down to this.
Don't need to. Don't need to. All right, whatever. So let me just focus here so I get the right areas. The first thing I'm going to do is give you some numbing medicine under your skin. All right? So that's going to help with any of the pain you might feel while we get started. So right 5.1, left 4.5, left 3.4. So I'm on the left side. You agree? And we need 3.4.4.5 over here. You're going to feel a little stick and burn. That's just the numbing medicine going in.
Ow, fuck yeah, that hurts.
All right.
Sorry.
No, it's okay. You're allowed to do that. I just don't want you moving.
Yeah.
So I'm trying to give it to you nice and slow so it doesn't bother you too much. Okay?
Can I have a warrant, please?
That's my hand on your back, by the way, just in case you were wondering.
Yeah, the hand's fine. The needle's the
Yeah.
one that hurts.
I know. I'm sorry.
Who said the needle doesn't hurt?
Actually-
And
Nobody.
I'll be honest with you, it's not even the needle that hurts you. Most people don't know that. Let's take some more local.
where did you need that kind of stuff?
It's the injection. Yeah, it's the medicine going in that actually hurts.
Oh yeah, that's what I'm talking about.
Yeah. The needle itself doesn't hurt, really. You won't even feel it. But when I put the medicine in, it's got, it's what, acidic, right?
Correct, pH is
Yeah.
low.
So nerves respond to acidic fluids or acidic environments, and they fire more. So it's the acidity of the injection that's the problem. On the right side, we're doing 5-1 and 3-4. That's just my hand, okay?
Yeah,
Just feeling around a little bit.
your hand's fine.
Yeah. Well, you're gonna not like the.
Yeah, I feel that one.
Yeah, it's the medicine going in once again.
Yeah, that,
I apologize.
yeah, fuck.
You're doing great, by the way. Everything's okay. I apologize.
Yeah, sorry.
I'm just numbing you up good right now so that we don't have to make you uncomfortable.
Yeah.
So what can you do for him? Maybe a little something?
Just have
Either
to
fentanyl or...
get rid of fentanyl and doing little propofol.
Mm-hmm. That's fine.
Small dose.
Yeah, for right now we can have that. No problem.
Sorry, this is,
No, no,
I gotta found out.
no.
We don't mind people with foul mouth. We're not going to hold that against you.
Alright.
That's the beauty of being in America.
All right. I would say 16 cc's
And,
total. You okay?
Yeah, as long as that,
Is that your arm bothering you?
not my arm.
How's our blood pressure? Looks good.
good, yeah, 1 or 2.
All right.
He's a super sensitive guy.
Understood. Left 4-5-5-1. So I'm going to start at 4-5. Sorry, 3-4-4-5.
No bones about.
You're doing great. Just relax and let me get this done. And then when you wake up, you'll be all done.
Good deep breaths, man.
Num num. You're doing great. Just only talk when you have a problem, okay? Or if I ask you a question. Otherwise, it's going to be hard for me to stop all the time and try to figure out what you're saying. That's uncomfortable?
Is that uncomfortable, Dad?
No, it's better than the last one.
Okay, lateral, please.
I still want to done the first one.
Okay, go back to sleep.
No problem.
Back to comfortable.
Everything's going perfect. Just relax, don't move. You're doing great. All right. All right, so I'm thinking I may want to start a little bit lower. As far as the fluoro picture goes, it looks pretty good. I think we could be just a little bit higher up. Just a little bit, maybe an inch at most. You're doing fine. Everything's okay. Shot? All right, let's try to line up. 4-5 looks really good. Let's try to line up 4-5. You're doing great. Just relax. Shot? Shot? How's he doing? Good. Shot? Yep, almost done with this. You're going to be very happy. Huh? Shot? Give me an AP.
What are you saying?
On a scale of 1 to 10, I'm putting it at 7.
Okay. We don't need to know that yet. We'll ask you that in a little bit. You're doing really good, though. All right, so my lateral is there. My AP is there. Yeah, we need to go more medial. Shot. You're doing great. Just hang in there. Shot.
That wasn't ugly.
I'm sorry?
That was a better one.
Good. I'm glad it's more comfortable for you. Shot. Give me a lateral. This is always the hardest part of the surgery for the patient, so you're doing really good. Perfect. Shot. Shot. See how the superior end plate of 5 is just not perfect? Let's wag it till we get it perfect. You've got your iliac crest offset. You should be able to see that, Jordan. Make those corrections without me telling you. Just take a shot. Other way. You went the wrong way, so let's go the other way. Shot. I don't know what you're doing. You're moving it, then it's moving back. So what are you doing? Release the wag. Take a shot. There we go. Lock it down. All right. Are you comfortable, sir?
Fairly secondary. Fuck,
Where do you feel that?
I feel that, fuck yeah.
Where?
Like in my kidney area,
Your kidney area?
well, in my, like, lower back.
In your back.
side.
In your back, right?
Yeah,
All right.
in my back.
But not down your leg.
Not
So
down my
going
leg.
down your legs, correct?
All right. Okay, just relax. Is that better?
Like right now?
Yeah.
Right,
Yeah, right this very second. Is it better?
ow, fuck. That one hurt.
Let's give some more num num. Blood pressure's good. Yep, perfect. Okay.
I feel that.
Yeah.
There.
I told you I'd give you more numbing medicine. That's exactly what I'm doing. That's why you feel it.
Okay, good.
You're doing great. Everything's fine. I'm just trying to make you as comfortable as humanly possible. Short of putting you under anesthesia. Yeah. Well. Now, how many of my surgeries have you watched online?
Uh,
You said you watched a lot, right?
I've watched about 5 of them, but I'll be honest, the majority of the time is whenever you push it in the straw.
I couldn't hear what. You watched where I pushed the straw in?
With the magic tube, and then I watch you vacuuming out the white cereal.
Oh, okay. So, how many surgeries have you watched? Would you say, if you had to pick a number?
I've watched components of
Shot.
at least 6.
Okay. See, 3, 4 is lined up nicely. I really like that. At least 6.
Yeah.
All right. Shot. And I know you don't have a very high pain tolerance, which is fine. Shot. That's it. All right. So, again, my goal here is to come in low within the foramen. Shot. That's very important. Yeah. Where do you feel that?
I can feel that
Where?
in my kidneys right near the skin level.
All right. Not down your leg.
No, not down my leg.
Shot. Okay. It's perfect. Shot. Let's get a AP, please.
I just don't know how well numbing it works for me.
It's quite interesting when I look at your spine. The 3-4 where I'm at now shows a really big foramen. It's perfect. It's like beautiful foramen, big, for the nerve to come out. And then when you look down at 4-5, it gets smaller, and then at 5-1, it gets really, really small. So you actually have something called spina bifida occulta, and I can see where your lamina didn't fuse in the midline at the L5S1 region.
I was actually told that.
Yeah. I mean, it doesn't cause people to have back pain, but it just shows that you had an abnormality in utero while you were developing as a fetus with the way your posterior arches closed in your spine. And a lot of people have spina bifida occulta. They don't even know they have it. It doesn't cause problems until the doctor finds it, like right now when I'm doing back surgery on you.
I was actually told that by a chiropractor talking to me.
Yeah, that's good. They found that.
Fuck,
Where do you feel that, Sean?
right near the skin.
Okay. Shot. That's it? Near the skin?
There, I feel it
Man, I can feel your herniation right here. It's incredible. So on your MRI, your herniation's a 3-4. Didn't look that bad. But right now, my needle is up against the herniation, and we're like at least a centimeter behind your disc space. So basically what it means is that your herniations are bigger in real life than you can tell on your MRI, which is a common thing that we find, you know? The herniation doesn't look bad. That's why the MRI is really a poor tool to be able to gauge whether or not a herniation is actually symptomatic or not. You can't. All you can do is see a structural abnormality and tell that there's a problem, but you can't tell whether it's causing the patient's problem. So I'm actually right on your herniation. I can feel it. Shot. And we're going to basically fix that when by the time you wake up, it'll be all gone. That went right through the annular tear. I could feel it. So we're done on this side. Now I got to work on the other side. Good news is I already numbed you up. So it may need a little bit more numbing, but hopefully not too much.
Coming, sir.
I'm just waiting for you to figure the right thing to do out.
Make good space for you.
I can actually feel some pain now happening in the lumbar region of
Okay.
like more sensible.
Yes, sir. Well, we're right near where your discs are, so I'm not surprised you're having symptoms right now. All right, so on the patient's right side, we're doing 5-1 and 3-4. Right, 5-1 and 3-4. So I'm going to go low. I need some more num-num. And you prepped wide, right?
Yes, sir.
So, I'm sorry?
Just numb me out.
Yeah, what's what we're doing? We're doing what we can, okay? You feel that? Yeah. Yeah. Well, we're just numbing your skin up. You're going to be okay. Like I said, this is probably going to be the worst part, hopefully. And then, of course, there's the discogram, right? You did watch the discogram, didn't you?
Yeah.
Okay, good.
I have some thirsty right now.
You remember what the discogram's all about?
Using that sort of X-ray.
That's where we do the
Ow, fuck.
sorry, just relax, you're fine. You're fine. Give me an AP. You're fine. Remember our deal, you don't come off the table, okay? I'm going to need to see 5-1. I promise you, everything is going okay. There's no problem. Yep. Let's go to a... You're doing great. Lateral view. Nice job, Jordan.
Go for it.
Is that better? All right, so I need to see 5-1, Jordan. Okay? Like I said, we're working on 5-1. That means you need to kind of get south and show me that 5-1 level. That's getting better. It's pretty close. So I would say based on the posterior sacrum, you're very close on the WAG, and I think we need to do a little of this. All right? Just a little bit. So before I'm going to advance our positioning needle, I want to make sure, there we go. I want to make sure that we've optimized everything. Now look how much shorter the pedicle is at L5. The pedicle is that piece of bone at the top of the foramen. It literally is probably a third of the height of the pedicle, I mean a third of the length of the normal pedicle, so it's very short. All right, we need to do a little bit more of this. I just don't know which way. Try that, let's see what happens. I think it's the other way. Try it, and let's see. Gosh, hard to say, but I think that's better. Right? What do you think, Luis? I think we need some WAG or something. That may be the best that we can do. That may be the best that we can do. Let's try. What do you think? Why don't you release both axes, the wag and the other. Let me see if I can manipulate this. Shot. Shot. That's worse, right? Shot. Are you releasing this? Shot.
Right here.
That's better, right?
Yes.
Wait, maybe too much. Shot. That's pretty darn close. We're just so far south, but I think we're pretty good there. Lock it down. It's maybe the best we can do.
Oh yeah.
What do you feel, Shot?
Just down deep, and I feel like that's on the front of my leg. Ah, fuck.
Where do you feel it, Shot?
Where do you feel it, Dan?
That's on the front side of my leg, just on the outside.
Uh-huh. All right, give me an AP. How you feeling now?
Okay.
All right, and the lateral is where? Over there. All right. I think we need to go a little bit more medial.
Ah, fuck yeah.
Just relax, don't move. Lateral. You're doing fine. Just
Hold on, fellas.
yeah.
Excuse me one second.
You squeeze her hand until she gives you some more medicine, okay?
I have it by continuous infusion.
Go north a little bit.
Actually doing a lot.
I know.
We need to center that 5-1 up.
So where is that coming from?
Shot.
10?
All right.
That's like, I feel it in my,
That's just my hand touching your back. Relax.
no, it's a lumbar.
Bring this up.
I feel it in my lumbar section.
I understand. Yeah, we're moving your spine a little bit with my hand. So you definitely have a low pain threshold, that's for sure. Okay, that's nice.
Crystal? Here?
That's really nice.
Oh,
Yeah, I like it.
Mary? You need some fentanyl and Reglan?
Reglan. Shot.
Yeah,
Shot.
that's more like it. That's, I feel pain. That's why I feel pain on the back of my leg.
Yeah. What's that?
That's why I feel pain down the back of my leg.
Yeah, but you don't feel the pain down now, right?
It's kind of lingering.
Where did you feel the pain?
I feel it down. It starts at my outside of my bottom, goes down my hamstring, and then it's kind of a little bit all the way down the outside of my calf.
You felt it down the outside of your calf?
Yeah, like still on the back side, but towards the outside of it.
Hmm. That better?
Is that better, Dan?
Yeah, it's better now. It's better now.
Shot. All right. Let's bring this side a little bit higher.
You let go of my finger. I just want to give him a little bit more sedation, okay?
No, 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 no. I don't want him to have more sedation.
I have just a touch of robotic sensory work.
All right, let's go. We're seeing almost the facet joint axis. It's not a wag issue. Go higher on my side. No, it's the opposite way. I think we've gone past our point. Let's go back a little bit. So that really wasn't too bad. Keep going. Shot. That may be the very best that we can get right there. Let's go AP and see where we are. His foramen is so narrow because the pedicles are so short. I think he's a little bit rotated at 5-1. For sure. Alright. Shot. I'm definitely hitting facet. Just lay still, okay? I'm as medial as I can get. Yeah, that's normal. Shot. Give me a lateral. And we're in perfect position. You're doing really good. I just have one more to do after this, and we're pretty much done with the 5-1, which is the hardest. And then we got one more 3-4 to do. So you're doing really good. I'm sorry it's uncomfortable for you. But that's the right spot. We're there. So one more to go and we'll put you to sleep, okay? You doing all right? Are you upset about your pain right now? If you are, I want you to just remember Dr. Kulkarni. Dr. Kulkarni. Okay? Just think Dr. Kulkarni. She's the one. Huh? I didn't hear what you said. Oh. That's not her hand.
He is protecting me.
What was the name of that movie with John Candy? You know which movie I'm talking about? Anybody know the name of the movie with John Candy? Right? Where he says, "What are you doing?" And the guy in bed with him is like, "I'm just putting my hand between the pillows." That's not the pillow.
Did you already do this?
What's the name of that? Planes, Trains, and Automobiles or something? Was that it? I haven't done the discogram. Don't put him to sleep yet. Huh? Well, yeah, we're not done though. You're gonna feel a little bit. Shot. AP. All right. You're good. You're talking a little too much. I need you to keep quiet so we can focus, all right? Just let me know if you feel a significant amount of pain. All right, let's get that L3-4. Let's get L3-4 lined up on the lateral view. Shot? Uh-huh. Go ahead and give me the lateral again at 3-4. Everything's going well. Alrighty. How you doing, buddy? All right, like I said, we're almost done. I apologize, but we just want to make sure it's done perfect for you. Perfection takes time. Yeah. Shot. So we're getting awfully close. Let's go back to an AP and see where we are. So once again, for those of you watching these surgeries, we use our x-ray machine because everything is navigated based on the spine, the bony spine, and the bones can be seen on x-ray. Just like captains in the old days used to use the stars to navigate. We don't navigate in the operating room based on the stars. We navigate based on bones of the spine. I think I need to be a little bit more medial. I'm going to start a little bit more medial. Shot. It's a little too high. Shot. Give me a lateral view. So, in an effort to do the right side through one incision, and that's spanning 3 discs, I can do it usually. I wanted to try before I don't do it, but I feel like we're going to be able to get it. So, the patient wants 2 incisions. Everybody wants as few incisions as possible. Um, so, I expect to be able to do it. We should be getting into the foramen. Nice and slow shot. How's he doing?
Doing great. Comfy.
I'm going to come a little bit lower than I am.
Hey, Dan, are you with me?
Shot. You're doing great. Okay, just relax. We're almost there. Shot. I just want to make it perfect, like I said. AP view. So once again, I'm going for the 3-4 disc through the right foramen. I've got the 5-1 on the right side already, and it's looking good right now. We're just entering the foramen. Back to a lateral view, please. And if you look at the spinous processes, just below the needle, the middle needle, you can see how it twists off to the side. That's the spina bifida. Just below that, you can see a separation in the lamina. That's what I was talking about earlier, for those of you wondering. All right, so shot. Shot. He's awake, right?
Yes. Hey, Dan.
Shot. Shot. All right, so we're right there. Let's just get a quick AP, see where we are in the AP view.
Give me a couple of deep breaths. Dan, take 1 or 2 deep breaths. We'll bring it in.
Yeah, don't sedate him anymore. We're almost there, and I need him awake.
Okay.
That's perfect. So I'm going to try to come a little bit lower, back to a lateral, but everything's looking good. Are you awake? All right, good. I just want to make sure you stay that way. But be ready, Dr. Calcarni. We're going to put him to sleep soon.
Yes, sir.
We need just a little bit more time.
Okay.
Shot. 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 Is that it? Okay, we're done. We're ready to test. Are you awake, sir? All right, well, here's where we're going to maybe upset you a little bit, but just lay still, okay? Shot. You comfortable? Is that uncomfortable for you? How bad did it get on a scale of 1 to 10? A 5, okay. That was 5-1, was a 5. Is that the area that you typically get pain? So that's a 5 concordant at 5-1. How bad is that on a scale of 1 to 10? 6.5. All right. That's why we can't give too much fentanyl right before this.
No, I didn't give them just the propofol later.
Yeah. All right. All right. So that was 3-4. You can see the 2 herniations, a double shadow. And that's what we're going to be repairing. Better now? All right. I have a feeling 4 or 5 is going to be. How bad is that on a scale of 1 to 10? 6.5. I like your little halves. What kind of engineer are you?
Petroleum.
Huh?
Petroleum.
Petroleum. Interesting. Okay.
He works with oil wells.
All right. Well, guess what? We get to put you to sleep now. Isn't that nice? We're going to start on this side. We'll just do 4 or 5 first.
So deep breaths.
Go ahead and count from 1 to 100. And, just go light, Dr. Calcarni.
Yes, sir.
Let me see where we are here. Shot.
You mean right this second is what you mean, right?
I mean, I don't want to over sedate him.
Okay.
And he's not moving. He's not really responding that bad, so we can keep him lighter.
Sounds good to me.
I just don't want him coming off the table. We've already, for some reason, the skin incisions really bothered him. Shot. We used Marcaine, lidocaine, epi, right? Some.
Percentage, like you said. Okay.
You used bicarbonate.
Oh, that's a good idea.
You put any
This is
bicarb in?
bicarb?
I don't know. Do we use any bicarb in there?
Do you normally use it?
I guess not.
See, 1 cc of bicarb for 10 cc of local.
You hear that? 1 cc of bicarb. Sodium bicarbonate. That will help when it goes in with some of the burning. Are you okay? You're doing great, by the way. We're getting ready to start your first one. This may be a little bit uncomfortable. Blood pressure's still good.
Yes, sir.
Everything's looking good. He's just leaning, airplaning a little bit away from me. But he had that before, so. Are you comfortable? Okay, everything's fine. Just lay still. Yeah, this is the painful part of the disc, so
Okay.
let me know when I can proceed.
Okay.
So we're bringing our dilator, which is that thing you're seeing on the left with the tapered tip.
Give me some deep breaths. Dan, in and out.
Hey, are you okay?
He's going to
Yeah, he's fine. I wouldn't put him any deeper.
okay.
Let's see how he does.
Relax.
You doing good? I know. This is the part that's you're not going to be happy with me about it. What did he say?
Cramps? Okay. Where are you feeling the pain?
Shot. Where?
Where are you feeling the
It's
pain?
okay. It's okay. We're almost done. Shot. Yeah, this is one of his painful discs, so he's going to feel uncomfortable. So for those of you wondering, patients having surgery that are semi-awake, we call it twilight anesthesia, is a very delicate balance between just the right amount of sedation and too much sedation.
Okay, squeeze my hand.
And shot. So the anesthesiologist has to really be very careful with how much sedation they get. Shot. Because too much, then they stop breathing and we can't ventilate them. It's bad. And too little, then they squirm around in pain. So you want to find just the right spot. And every patient's different. Therefore, it's a difficult challenge. So, but we always would rather err on the patient being more awake than too asleep. Otherwise, they stop breathing, and then it's a problem. So. The other thing I notice is that everybody wants to be asleep for their procedures, pain management procedures, yet, scope on, yet they usually don't understand that there's a risk to being asleep, a risk of anesthesia, of not waking up. Fortunately, I've never had that happen in 22 years of doing surgery, but what's wrong?
Nothing.
Huh? Anyway, that's the disc down there that we're seeing. It's blue because it's degenerating, and honestly, this doesn't look like it's that old of a disc, which is nice. It looks like a younger herniation, which means less scar tissue inside the disc from the inflammation, which means it's going to come out quicker and easier for the patient. Okay? But definitely abnormal. We're using the blue fiber, which is a laser fiber, and at the tip of that is a little glass wire wipe. And that glass wire is what carries the laser beam or laser energy. Your headlight's right in my eyes, Dr. Calcarni. It's okay. I know you don't do it on purpose.
No, sir.
Or do you? I'm just kidding. This is the herniation I'm working on right now. You can see how the nuclear material is shriveling up with the laser. The laser is truly the best way to fix a herniated disc. I've been doing spine surgery for 22 years as a neurosurgeon, and in 22 years I can honestly tell you I've used all the instruments, tools. I know everything that's available out there, and I've tried it, and the laser is by far the very best tool in the world for fixing herniated discs. It's the most precise, accurate, least damaging to tissue, and it gets the job done. So it's kind of like if you have to dig a hole in the ground, you know, you use a backhoe. Everything else is like using a bulldozer. Obviously, I'm not talking about a giant excavation. I'm talking about a smaller hole. So an excavator is the right tool, and the laser is kind of like an excavator. It's extremely precise, accurate, and it doesn't take out too much, doesn't take out too little. It just takes out the right amount. Whereas the other tools available for spine surgery, available to neuro and orthopedic surgeons, take out probably too much or not enough. So on both sides of that. And I've used them all, like I said. I've been trained extensively in traditional spine surgery, decompressions, reconstructions, osteotomies, instrumentation, fusion techniques, all different types, artificial discs, and of course endoscopic surgery. And of all the techniques I have available, which is pretty much every technique in the world, that I think the surgery with the laser is by far the safest and the very best because it's so precise and safe, accurate, minimally invasive. It's the least invasive of all spine surgery for disc herniations. All right, let's get some questions going while our patient blissfully snores and he gets his herniated disc fixed. Just for the record, this patient didn't have gigantic herniated discs. His herniations were pretty small, but he was severely debilitated by his herniations. They were causing severe symptoms that basically prevents him from living a normal life. Now, I had conversations with his father, and the father also has had some problems with his discs, and the father has gone overseas and had major surgery with artificial discs at multiple levels. But of course, the father wasn't aware that this technology was available. And honestly, I think that there's a very good chance we could have fixed the father's problem as well with the laser. But, you know, that's just my opinion. I don't know that he would agree with me, but that's okay. I'm not trying to convince him otherwise. He's had his surgery and he's very happy. So I personally don't like the artificial disc technology because the complications that can happen or do happen from the surgery are very severe going through the belly. If you have an outstanding surgeon that does artificial discs, you probably get the very best results. And in my opinion, the very best results still are not anywhere near the results of the Duke laser disc repair with artificial disc surgery. And I'm happy to challenge any spine surgeon in the world to compare results and even to treat patients going forward and see how they do, one versus the other. This is the annular tear right here that I'm zapping at this very second. And you can see the tear starts right there with that crack to the right, and then the other side of the tear is over here, and there's a massive tissue right here just wedged in between the tear. This massive tissue is called the interposed nucleus pulposus. Interposed, interposed. Now, you're not going to hear that from most doctors because they have no clue what interposed herniation means. But when you talk to an endoscopic surgeon like myself, most of them know what the interposed herniation means. It's the part of the nucleus pulposus that's squeezed out through the annular tear that never made it all the way out. So if you think about a volcano, and the top of the volcano being up here, and the bottom of the volcano being down here inside the volcano where all the hot liquid magma is, that magma that's going to come out, that lava basically, is the nucleus pulposus, buried deep inside the disc. And then a crack occurs in the annulus fibrosus. That's where the volcano opens up, and then all that pressurized material from inside spews out of the volcano. That's your magma coming out as lava flow. Anyway, so all this nucleus jelly starts squeezing out through the tear, but not all of it makes it out. Some of it gets trapped inside the tear because it doesn't have enough oomph to get out, enough pressure to get out. So it gets stuck in the tear. Guys, why am I hitting my knee against something here on the bed? It's just the bed?
Check that.
No, it's just the bed, I think. I think the patient is too... Wait, no, something moved. I hit my knee against something and it moved to the other side. Never mind, it's a C-arm. For God's sakes, Jordan, come on. Ugh. I told you, surgeons like things done the same way every time, for a reason. All right, sorry, I'm having a moment. Kind of like a moment that Dr. Jekyll has or Mr. Hyde has just before he turns into Dr. Jekyll. That brief moment of melodramatic dancing on the brink of sanity. All right, anyway. The interposed nuclear material is what causes the inflammation within the annular tear, and I'm removing it right now. So by doing this, I'm going to get rid of the inflammatory nidus, is the word we like to use in pathology and medicine. Nidus. Nidus means a source, a site, a location of something. The nidus of infection, or the nidus of inflammation, or the nidus of pain. It means the source. So I'm removing the source of this patient's problem with his disc herniation, which is the herniated part of the disc. And it's ignored by surgeons because A, surgeons can't see this, but B, with a microdiscectomy, you can't see it, you can't fix it. It's impossible. All the microdiscectomy can do at best is to take out the free fragment of herniation that's sticking its head all the way out the volcano, basically to clean up the lava that's already escaped the volcano. Well, this is lava that's still inside the neck of the volcano, from the mouth down to the base. And this is the problem. This is why people have back pain. This is mostly why they have leg pain. This is what other surgeries don't fix. This is why our surgery has the very best outcomes. Our outcomes, are they perfect? No. They're pretty darn close though. Our average is 95% relief of back and leg pain, basically numbness, tingling, weakness with the surgery, the Duke laser disc repair. And that's possible because of what I'm doing right now, removing the interposed herniated disc. Okay, so big herniation here. Here's the annular fibers, they're all scarred up. You can see the golden color is from inflammation and calcification. The body's response to abnormal inflammation in the body is calcification. It's called dystrophic calcification. And I can see these tissues are calcifying abnormally because of all the inflammation that's been going on inside the annular tear, right here, right where the herniation is. It's a big piece of herniation right here. I'm trying to free it up because it's attached to the annulus from all the inflammation and scar tissue that's been laid down over the years. Stand by, see if I can grab it out. So everything in a herniated disc begins with a tear of the annulus, and after the annulus tears, the nucleus squeezes up through the tear like lava coming out of a volcano. Oh, there's so much. And then that lava just sits in there, or the nucleus sits in that tear, and every day that it's sitting there, it's causing more pain, more inflammation, right? So it sits there until Dr. Deukmejian comes and takes it away. The other way to get rid of it is a fusion. If you take the whole disc out completely, then you can probably get it out, though artificial discs don't really take the whole disc out. They leave the annulus, and it's the outer annulus where the problem is. So, plus you have movement at the disc. So that's why, unfortunately, a lot of artificial disc patients, surgeries don't work, and they still have pain, because either the facet joints start causing pain, or the disc herniation, which was never really treated, keeps causing pain, or starts causing pain again. So anyway, I'm just talking you through understanding the pathophysiology of herniated discs, because nobody has asked me a question yet. Do we have any questions?
We just got one. One of our viewers is wondering, what kind of symptoms are you treating with this procedure right now?
We're treating back pain that's coming from the herniated disc. And we're treating leg pain, leg numbness, leg weakness from the nerves being pinched and irritated. Basically, we're treating a herniated disc that's causing symptoms. Most herniated discs don't cause symptoms, but in some people they do. And honestly, I find there's a genetic predisposition to herniated disc causing symptoms in patients. AKA, it's familial. It's not really familial. Familial is like something that you get because your family does something behaviorally. Genetic is something you get from your family that's passed along your DNA. We're okay. Yeah. So familial, let's say your family lives near a, what were those mines? A sulfur mine, right? A sulfur mine. Your family lives on the brink of a sulfur mine. And everybody in your family goes and collects sulfur. And everybody's skin turns red. Well, your skin's going to turn red if you go and collect sulfur too, because it's a familial thing. It's something that your family, it does, and you've gotten this physical condition now as a result of your family doing it. Genetic is something that you can change where you live and you're still going to get it. You can move, you can do different things to try to get away from that inheritance of that trait, that phenotype, but you have the genotype, which means you have the genetic code for that phenotype, that physical, characteristic. I won't say abnormality, but it is bad to have symptomatic herniated disc. So, long story short, we're fixing a patient whose herniated discs are causing their back pain, their back to hurt, and their leg to hurt, and their leg to have other symptoms. All of this is the herniation, by the way. This is just really big. When you look at this disc on the MRI, it doesn't look so bad. But this is a condition that I did not originally describe, but it was described as internal disc disruption. And this is a condition that actually chiropractors, I think, were the very first to describe it accurately, is that even though the disc looks good on your MRI, it's totally jacked up on the inside. So it would be akin to a person on the outside after a car accident. They look fine on the outside. There's no bruises. There's no swelling. But on the inside, all their organs are damaged massively. So they have internal damage. That's kind of what I'm seeing here. There's the tear right there. That's not normal. I call that the spider sac. And we got to zap it away. That's the source of the pain. The further out we get to the periphery of the annulus, the more involved that area will be, that tear will be in generating pain. So it's important if you do this type of surgery in the future, if I've actually taught you something and you go on and you try to help people by doing endoscopic spine surgery, the Duke laser disc repair, it's important to make sure you get the tear debrided all the way to the periphery till you basically get to the epidural space. Okay? I was talking to my son, Arias, he's 15, and my daughter, and I told him, listen, if you want to carry on your family tradition of being neurosurgeons and spine surgeons, I'll be very happy and I'll teach you everything. But who knows how long, we don't know how long we all have in this world. So I said, make sure you go and watch the videos that I've created. And you can become the best in the world by just following my principles. Maybe someday there will be a better way of fixing herniated discs, but I don't foresee it right now. I don't see how that could be. Now we do sometimes do stem cells, but stem cells really won't take the pressure off the nerve. So if a nerve is being compressed, they won't do that. Stem cells can definitely reduce inflammation if done properly, but you have to have the right kind of stem cells done. There's different kinds, and you want to go to a reputable doctor who has great success and a low complication rate. Duke Spine Institute does stem cells, and we do PRP, which is platelet-rich plasma. All right, did I answer the question for our viewer? Are they
Yes.
satisfied?
Yes, and we have another one.
We have another question.
One of our
Before you
viewers-
give me the next question, I'd like to say something. So for those of you who don't know Duke Spine Institute, we're located here in Melbourne, Florida. Duke Spine Institute actually has a Facebook group. So we have a Facebook group so that we can help people. It's free of charge, and you're welcome to join. Just request to join our Facebook group. It's called Spine Surgery Support Group. Spine Surgery Support Group. And Spine Surgery Support Group is a great place to go and learn about back and neck conditions, spine conditions, and how they can be treated, or you can hear from other members like the problems they're having or successes that they're having, with their treatments. So it's a really great forum, and we don't really allow advertising, obviously. It's really not for advertising. I go to other forums on Facebook, and a lot of them have nonsense advertisements for things that don't work, contraptions that don't work, or treatments that are bogus. And we don't allow that on our support group. We don't have a surgery support group to sell advertisement and make money. We have a support group to help people who are suffering. And those are the people that are most important to Duke Spine Institute. How's our irrigation going? Because I'm getting a lot of debris. Can you look at that? Are we doing good? All right, so I'm just about done with this disc at this side. This is L45. This was probably, in my opinion, the most painful of all three, though I was surprised. 3-4, I think 3-4 is pretty painful as well. He has annular tears. Now 5-1 was not a disc that I thought was causing a lot of back pain, but it was a disc that I thought was pinching his nerve, causing his leg symptoms. And this patient has sciatic pain down his leg, into his calf, on both sides. He's got, radicular pain shooting down the leg. So I wanted to make sure that we addressed all of his leg symptoms with one surgery. And that's why we're doing this surgery right here. I think this is going to give him the relief he's looking for. The only alternative, in my opinion, would be an artificial disc surgery or a fusion surgery, and those are not better alternatives. Not for a young man, and not knowing the risks that I know with open surgery. What's the other question?
We have a viewer who's wondering, what would the downtime be after surgery for this patient?
What would the downtime be after surgery on this patient? So there's no downtime at all. This patient is going to be walking around today after their surgery. They're going to go back to their hotel. They're going to go out to dinner most likely tonight, I hope. And basically feel fantastic today. The only thing is he can't drive a car. Can't operate machinery. He just had anesthesia. So that's a rule for anybody having anesthesia anytime. You cannot get on a lawnmower or start your weed whacker or a chainsaw up and go home and start cutting your branches. You know, you're going to mess up bad and you're going to hurt yourself or someone else. So you cannot operate machinery on the day of your surgery. Aside from that, he goes back to being normal today. Okay? Now, he cannot bend over and pick things up from the ground. Nobody can. And he cannot lift anything over 25 pounds, so no suitcases. That's why dear old dad is with him. And his father is going to make sure he behaves. Stand by. We're just about done. A little bit of bleeding there from one of the bone spurs. He doesn't have very big bone spurs. His bone spurs are pretty small, but this guy looks like he wants to come out later. I'm not going to let that happen. Other than that, we're pretty much done. There's fibers of the posterior ligament. There's epidural fat. There's where the herniation was. All right. His nerve root is right up here in the foramen, just below all that fat. So the herniation's gone. You see the hole? I just want to look lateral here and zap a little bit more in case he had a lateral herniation in the foramen. A lot of people do. And I want to take care of this lateral part. Okay, I can't find my foot pedal. There it is. You know, I honestly don't like this little foot pedal. I like the other one better.
The one inside the box?
Yeah.
Okay.
Well, I don't want to buy another one, but if they're willing to trade it out,
Yeah, but if
I don't know if it's
you
more
wanna try it
expensive
out,
or not.
No. You said the
I think he's right.
The old version?
The old version?
It's like a little box.
Will that work though?
I can ask the rep.
All right. I don't know if that'll work with this one, but yeah, if we can find a cheap one or if they're willing to trade it out. All right, looking good. Standby laser.
Hey, that's all.
So we're done here at L45 left side. That was one of the discs that we're fixing. All right, done. Scope off.
Have two more to do, or?
3. Take. I'll do that. Okay. So, tube comes out. Apply pressure so he doesn't have any bleeding. How's he doing? Good. Guide wire. Fluoro in. Go ahead and give me a lateral. Let me know when you're getting ready to take the picture. So we're going to do the 2 discs on the left first, and then we're going to move over to the right side. Go ahead. Little pressure shot. Okay. All right, so I need to see 3-4, which is good. What else? Let's get rid of this because that's kind of obscuring our view. Can you show me 3-4 a little better? I think you need to bring the table up or fluoro to the ground. Shot? All right, that's good. That's good. I'm happy with that. Just stay there. Okay, so I've got the guide wire in. I'm going to take this Needle out, shot. I think I see it there. Shot. Yep, good, good. Remember, we have 2 needles in it at 3-4 because we're going on both sides. He has tears with small herniations within the foramen on both sides. And as I pointed out earlier, those herniations were actually bigger now than they were on the MRI. I don't know if they've gotten worse, shot, or if it's the way he's laying on the table, you know, but the herniations are much bigger right now than they were before. Shot. So we're going to get in there and, oh yeah, he's moving around. He doesn't like these herniations much at all. Just lay still. You're doing fine. Shot. Yep. Yeah, right on the herniation with the tip. You can see that. Yep. He's not happy. So I'm going to wait. Keep pressure. You're doing great. Lay still. Just lay still for me. You're doing good. Lay still. You're doing good. Everything's okay. So movement during surgery like this is common. It's usually reflexive, meaning there's no consciousness. It's just the human body responding to a painful stimulation, even though cortically they're suppressed. What's going on, Dr. Kulkarni? What's that?
I think I'm good. Go ahead.
Take your time.
Yeah, I'm not
Take your time. Yeah, he's wiggling a little too much for us. That spot on the disc is just very tender. Shot? Let me know when I can proceed. Maybe what I'll do is I'll just go ahead and bring it through, and then that'll ease up some of the pain. Hold them. Shot. I'm okay with a little bit of movement. Shot. Let's go, Jordan. Shot. All right. So that's the worst part right there. He seems to be okay. Shot. In terms of an anesthesia standpoint. Shot. 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 Just about done. That should be it. Shot. Let's go, Jordan. All right. Good. Okay, that was stimulating for now, and then probably 5 minutes. You won't have much. Get the fluoro out. Scope.
Scope on, please. Lights off.
I need to see.
Ankle.
All right, fine. Okay. Again, the disc, laser. How's he doing?
Great. All good. Michael,
Yeah.
do you have a suction catheter?
Down below. Bottom drawer on the right.
At the patient porch?
No, in the cart right now. Should be a couple salt catheters in there.
Got it.
Any more questions from our audience?
None at the moment.
Huh?
None at the moment.
Okay.
Actually, we do have a question from Twitter. One of our
Yes.
viewers asks, for herniated discs, what is the standard of care that is agreed upon by most surgeons? And if it's not this, why isn't it?
So you gotta raise your volume. I couldn't really hear your comment. Something about standard of care and
Is this a little bit better?
yeah, try that.
Okay. The viewer asks, what is the standard of care for a herniated disc that most surgeons agree upon? And if it's not this procedure, why isn't it?
Well, great question. So standard of care for a medical problem doesn't mean that there's only one treatment. There are many treatments that are considered the standard of care. Endoscopic spine surgery is one of them, and it is the standard of care. Is it what most surgeons would do? No, not necessarily, because they don't know how to do it. So for a surgeon to be able to do surgery, they have to be trained to do it, and they have to know about its existence. They have to be trained to do it. They have to be trained to do it properly. They have to be trained to deal with complications should they arise. So there's a lot of training that needs to be done to be able to do a new surgery. There is no standard surgery, but there's a lot of treatments that fall under the standard of care. So if a patient has a herniated disc, they have pain, one standard would be to send them to therapy for 6 weeks. Another standard would be to send them for 8 weeks. Another standard would be to send them for 10 weeks, 12 and a half weeks, 18 weeks, whatever. The point is, therapy would be a standard. Shots could be a standard of care. Epidurals, facets, anti-inflammatory, oral anti-inflammatory meds could be a standard. So what I'm getting at is there's no one treatment that everybody agrees to for every patient. That's the art of medicine. That's why they call it the art of medicine. Now, when it comes to taking a brain tumor out, you'd think that there would be agreement among all surgeons of the right treatment, but guess what? That doesn't even exist. Some surgeons want to biopsy the brain tumor, take a little piece. Other surgeons want to do radiation instead of open surgery. Other surgeons want to do open surgery. Other surgeons want to do chemotherapy with medications in the veins. So the problem is there's no what we call consensus, where everybody agrees 100% all the time for this situation. And that's just how medicine is. I mean, look at all the different blood pressure medications there are available to patients. Why isn't there one that's the best? The reality is that every medication works differently in different patients. So there needs to be more than one choice. And when it comes to surgery, is there, one choice, only one? By the way, what we just saw down there, you see that silver? What do you think that is? Do you think we found a silver mine in his back? Nope, that's the needle on the other side. Remember, I put 2 needles at this disc, so we're seeing both. Why do we have to go on both sides? Because he has herniations on both sides. And fixing one side won't fix the other, usually, okay? So if there's a big enough herniation on the left and a big enough herniation on the right, you better be doing both, or the patient's going to come back again and need another surgery. So there's no consensus on what the right treatment for a herniated disc is among anybody in spine care. What I'm sharing with the public today and every day is my experience, my opinion, but it just so happens that what I do has the highest success rate of any treatment in the world. That's kind of why I'm sharing it with you. This isn't, well, here's Dr. Duke's opinion, one of a 10,000. Here is the surgeon who's getting the best results in the world, treating back pain and neck pain and treating herniated discs. And now I'm sharing my opinion with you. There's the annular tear, by the way. Look at that. I talk about it all the time. There's the tear. It's right there. If I move this a little bit, you see it better, okay? And there's some redness on there. That's the inflammation and blood. So I have to zap that away. By taking this away, I'm getting rid of his back pain at this disc. At this disc. Okay, so remember, each disc can be a pain generator in itself. And each disc has two sides. So you can have a right disc tear pain generator at 3-4. You can have a left. You can have a right and a left 4-5, a right and a left 5-1, a right and a left 2-3, and then you got other joints too that cause pain. So there's a lot of different pain generators. That's part of the reason why doctors don't always agree on the right treatment, because they don't agree on the right diagnosis. So why do we share Duke Spine Institute experience with the world? Because we think it's so important that people see this before I die and I can't operate anymore or teach anymore. It's important this gets out. It's very, very important that it's not lost. You know, in the old days, thousands of years ago, if somebody had a great idea that made life better for everyone, they would share that idea with the community, usually in a campfire or in where did like Aristotle preach? Some type of a forum. So the forum that I'm sharing my knowledge and experience with, that I think is so important that it's not lost in the future when I'm gone, that forum is through these videos that we're doing live broadcasts. So people can ask questions and we can share ideas and information. But the fact of the matter is that because I'm in private practice, I don't have residents to train. Because I'm in solo private practice as a neurosurgeon practicing here in Florida without other surgeons, there's no one to pick the reins up after I'm gone. And I've been thinking a lot about that, and I think that's a shame that this very special surgery would disappear. You know? That would be like the recipe for Coca-Cola dying when the founder of Coca-Cola died, right? And then nobody would be able to enjoy a Coke. I don't know if Coke's the right thing, but Coca-Cola is something special, and gosh, there's billions of bottles of it sold a year, so clearly people like it. And boy, wouldn't that suck if there was no such thing as Coca-Cola? If we just had water to drink all the time? What?
Sorry, I just need.
How dare you interrupt my Coca-Cola discussion?
Sorry, sir.
My point is that unless you put it down somehow, it's going to get lost forever. And this is not the kind of surgery that you can just write a book about it. You know, the picture's worth 1,000 words, and we have millions and millions of pictures. So we have 1,000 million or 1 billion words to say about it. And showing you a video of the surgery shows you every possible variation that I've encountered in the last 5 years that I've been broadcasting these surgeries, every single one of them. So it helps the future surgeons understand what to do given a circumstance. Like, how did Dr. Duke deal with it? How did the founder, the originator, how did the original pioneer deal with these same issues we're dealing with? Why do I share it? Because it could make the difference between life or death. It could make the difference for the patient. It could make the difference between success and failure at treating their symptoms. So For me, it's very personal, deeply personal. I'm committed to fixing people's back and neck pain. That's what I've dedicated most of my life to, as well as saving the coral reefs. And I have to do things to the best of my ability. That's just the way I am. And showing a video of the entire surgery from beginning to end, seeing what the surgeon sees, dealing with what things the way the surgeon deals with them, that's the best way I can do this. That's the best way I know how to do it. I could go to the university and start teaching surgeons, yes, but I'm waiting for a university to basically come to me and say, hey, we're so impressed with this technology, we want you to move here and we want you to do this surgery here. And I may actually take them up on it, okay? Depends on where they're located. Fact of the matter is I'm situated here, and I've built a very successful spine practice, and we've helped tens and hundreds of thousands of people now. And at some point I'll be prepared to move out of Brevard County, but for right now, Brevard County is my home. And so for me to teach at a university, I would have to leave my home and teach. And I'm not too keen on that, because after all, remember, I left my home and traveled around the world to learn the basics of this endoscopic spine surgery. So why shouldn't other doctors travel here, right? If they want it bad enough, they'll come. So I think that day is soon to be here. I have a lot of inquiries about doing a fellowship, and I'm open to training other surgeons. We offer fellowships. So happy to do training as long as the doctor is the right doctor for me. I'm not going to teach a surgeon how to do my surgery who's then going to go out and screw it up and hurt people. So it has to be done properly. That requires a special kind of person for me to train. And I'm not just going to train anybody. So I know my children are capable of doing it right. And if they're going to be the next Duke laser disc repair spine surgeons, then so be it. I hope there are others, but if not, then that's the way it's going to be. So when you ask about a standard for treating herniated disc, there is no that everybody agrees upon, okay? However, there should be, and everyone should be equally well trained to do this type of surgery so that their patients can have the Duke laser disc repair. There's not a single spine surgery that I can't perform myself. I'm extremely well trained in spine surgery. If you think about the United States and its position in the world with respect to medical technology and medical ability, you may not appreciate it, you may, but the United States still has the best trained doctors in the world, in my opinion. Of course, there are some really good ones in Germany and South Korea and other countries, but if you think about, I've been trained by the very best in the United States in neurosurgery, and I'm a leader, a pioneer in my field. So should this be the standard surgery for a herniated disc? Absolutely. Will it be the standard surgery? Most likely. What's keeping it from being the standard surgery? Surgeons don't know about it. And also we have other forces that are in play that are pushing back. One of them is the companies that make the screws and rods and artificial discs. They want to make their profits. And they get profit when they sell you an artificial disc to go in your body. They make profit when a screw gets put in your back. They make profit when a cage gets put in your neck. They make profit when rods and screws get put in your spine. Well, those powerful companies run this country, unfortunately, along with the insurance companies, and they don't want this surgery becoming popular. Because I'm not putting any hardware in. I'm not putting screws and rods, cages. I'm not doing any fusions. So they're not making any money. Frankly, they hate me. I'm sure there's a sniper out there in the bushes waiting for me to step out of this building this afternoon to put an end to their misery. Fact of the matter is, this is big business. This is big money for them. And they don't want my ideas being shared around the world, because this is going to put them out of business, pure and simple. It's literally going to put them out of business. And that's really what's happening. So I'm not going to concern myself with them. It's not my fight. It's your fight. if you're watching this surgery saying, I wish this was available where I live, I wish this was available to me, well, get up off your ass and do something about it. Make it available. Stop complaining. You know, nobody ever gave me anything for free. I had to go work and earn everything I've done. And certainly you all want great medical care. You want the best surgery in the world, then get up and do something about it. Fight your insurance company. Sue them. We do it all the time. We win. That's the best thing you can do is if your insurance company doesn't pay for your surgery, file a lawsuit. Show them how serious you are. And guess what's going to happen? Enough people do that, they're going to start paying without making you actually have to file a lawsuit. I have the answers for you, but I am not the answer for you. You're your own answer. You have to empower yourself. You have to be committed to fixing the problem yourself. Is this the standard surgery? No. Is it a standard? Absolutely. There is no one standard, but this should be the standard for everybody that has a herniated disc. When I'm done with this, you're going to see what was done. Everything was done through 2 tiny little cuts on the back, and those cuts are going to be covered by Band-Aids. And this patient isn't even going to have really a suture put in their back. They just have 2 Band-Aids. And they're going to be up walking around tonight, and if you know this patient, you can call him and talk to him. And you're going to find out that he's going to be doing A-OK. All right. That was a big herniation again. Deceiving on the MRI, looks smaller, was actually a lot bigger. Again, this patient has what I would call classical internal disc disruption. Basically, the inside of the disc is horrible looking when you actually get here and look at it, but on the MRI you can't tell. So, very common, unfortunately. Here we are in the epidural space, the last of the herniation right here. I'll zap this away and we'll be done with this disc, and then we're going to switch to the other side. We've got about 30 more minutes. Patient's doing really good. No issues here for me. So I'm just cleaning up the annular tear, getting rid of the interposed nucleus. You have another question for me?
None so far.
Okay, great. The nerve is up here, right over there, on the left. Looking good. Just in that fat right there. I want to make sure I don't need to take any more of this stuff. It's a little grungy because of all the inflammation that's been going on. It's got a lot of scar tissue. I'm not going to be able to get all the scar tissue out, but you don't need to. You just need to get the part of it out that's right next to the nerve that's actually affecting the nerve. And I've done that. And I feel really good about it. Remember, you don't want to gild the lily. You don't want to do too much and then cause a problem. So, but I can tell you, I'm really impressed with how bad this disc has been damaged. It's, you look at the MRI, it doesn't look that bad. I knew there was something there because I could see it, but I didn't realize it was this extensive. This is, it's like a sinkhole, you know? So, you don't really see this much damage on the surface. On the surface, it looks like there's a little problem, but underneath, there's a huge, huge problem. So, I still think he's going to do fine. But I am concerned with the extent of damage he has to his disc. It looks like he must have crushed the disc at some point, you know, a long time ago. And then the disc just kind of scarred in and healed partially. That being said, I think he's going to do fine. Time will tell. Okay, we're done here. All right.
Lights out, please.
Scope off. We're done on his left. And
One more, right?
no, two more. I told you, two more. Two more. So we're going to put some pressure on the muscles just so that they don't bleed at all. We've probably lost 3 or 4 cc's of blood, very little. And this is pretty much a bloodless type surgery. You are going to lose a few drops. But compared to open back surgery, this patient would have had to have 3 discs fixed to treat his symptoms of back pain and leg pain, numbness, tingling, weakness. And that would have been a pretty big surgery by any account. So we're doing all this through 2 7mm incisions. Okie doke. Let's switch sides. Move out of the way, please. Put that back. Go to your other side. Any questions for me?
Not yet. The audience is being pretty quiet.
All right. Audience is being quiet. Ah. Interesting. What is this cable? Is that a laser or what is that? That should not be there. Please move that. All right. Guide wire. Now, at L5S1, which is the next disc that we're going to fix, this patient had a herniation on the right side, and it was pushing on the nerve root. So this is one of those things where we got to get the pressure off the nerve root. Shot. Watch it.
We do actually have a question now from Facebook.
We do. All right. Fire away.
One of our viewers is wondering, are there things that we can do as patients to help going forward to prevent future inflammation or calcification?
Well, obviously the best thing to do is to avoid injuring your disc in the first place as much as possible. So, but unfortunately, I'd have to be honest with you, every single human being alive over the age of 45 has a herniated disc in their body. So we all injure our discs throughout our lifetime by doing things, whether even if it's just normal, like, you know, kitchen duty, lawn duty, whatever, yard duty, you're going to end up, you know, potentially hurting your discs and injuring them. And the reality is that there's a certain, I'd call it a phenotype. Shot. If you understand genetics, you know what I'm talking about. There's a certain type of person that when they do injure their disc, it actually hurts and doesn't get better because it doesn't heal. Shot. And that person, that phenotype is just destined, unfortunately. Shot. They're just destined to have disc problems. I need the table up a little bit, please.
How much?
I don't know.
Okay.
Shot. It's good. Why are you not getting 5-1 where I need it to be? Do you think Tinkerbell is going to come in here and direct things? I shouldn't have to stop what I'm doing. Okay, Jordan, we've talked about this before. You've got to figure it out and get it done. Okay? So what I'm saying to you folks is that if you have a herniated disc and you have the wrong phenotype, that you're going to end up having pain from that disc no matter what you do. And this is too close to me, okay? You know, you're supposed to be zoomed in so that this is away from me. Shot. Oh my God. Lord have mercy. Let me have that. Sorry. I'm struggling with my staff right now. Trying to line up the fluoro properly. Oh boy, dude, you're killing me. Move Luis's side north. Yeah. How's he doing? You know, every time you hit the button, you give radiation, right? So the fewer times you hit the button, the better you're doing your job. You've hit it twice as much as we need to be doing it. Okay? You need to get it right, Jordan, or we need to get somebody else in here who can do it right. Have a talk with Monica. I don't know what else to do. Shot. How's our patient doing?
Patient is good.
Yeah.
Why?
I don't know. He's just maybe tightening up. I'm
Well,
having a harder time.
he's as sedated as he can be.
No, I don't want him any more sedated. I think that's going. Shot. Yeah. Shot. All right. Give me an AP. That's fine. All right.
We have another question.
Yeah.
A viewer says, "Hi, my doctor told me that my spine is slightly curved to the right. Can that be causing me back pain? I don't think it's discogenic because when I lay down, I have no discomfort."
All right. So great question. Thank you for asking. One of our viewers says, Dr. Duke, I have a question. My doctor says my lateral, please. My spine is slightly curved to the side, and I want to know, we call that scoliosis, by the way. I want to know if that little bit of scoliosis could be causing me pain. And the answer is, I am 99% sure the answer is no. Okay, so no. What's most likely causing your pain is your facet joints or your disc. And without doing an exam, without like looking at you, I can't tell which it is. Okay? So, but the answer is you have a fixable problem, and the most likely fix is the surgery you're watching right now. We fix pain from scoliosis all the time using this surgery. And it's not the scoliosis itself that causes the pain. It's not even the muscles. It's the disc or the facet. Either one we can fix, not a problem. So I'd recommend you come visit us and or send your MRI in, and I'll be able to tell you. If I could read you, if I could do an MRI review and I could see you on Skype, that's good. If I could see you on Skype and do a little video conference,
Stop on.
I could see where your pain is. If you could point it out to me where most of your pain starts, then I can tell you based on the MRI and your physical exam over the Skype, I can probably tell you what your problem is and what needs to be done to fix it. We do that all the time. Most all these patients, they come to me for exactly the same reason. And we see them on Skype and we're able to figure out what's wrong. And then we can do their treatment when they get here. Don't move, you're doing fine. So I'm at L5S1. There's a lot of annular inflammation, as you can see. Laser.
Excuse me, one sec, snoring away, but
Yeah, I understand.
just give me one sec.
Take your time. So, I can usually tell where people's back pain's coming from as long as I have an MRI
Michael?
and a physical exam, which I can usually do over Skype.
Okay, it's okay, it's okay, it's okay.
Obviously, I can't check your strength
Great, you're doing
or
great.
your feeling,
You're doing great.
but I can certainly see where your pain's emanating
Michael,
from.
I need the
And
left
based on my
hand
many
down.
years of experience, I can usually tell
It's okay, it's okay.
what needs to be done. Dr. Calcarni, everything okay?
Yeah, he's just, everything's in
Can I proceed or you want me to wait?
let me see, I bent up
Let
on
me see how he does.
let's see, you can try, maybe not.
Yeah, we're in that painful disc of his. That's probably why he's responding. Hey, Mike, can you give me the laser or not?
Press ready. Ready.
Thanks.
It's okay, it's okay, it's okay, it's okay.
So this disc is more collapsed than the others. Want me to wait?
I think so, though.
Yep, no problem. We'll wait.
Stand by. Press the stand by.
You don't need to stand by. You can just wait. Unless it turns itself off.
Okay.
This is a perfect time for some more questions. Let me know if I can proceed.
Ready. Press ready, please.
Yes or no?
Thinking, okay, we can give it a try. And
Yeah. He's not, from my standpoint, he's moving a little bit, but it's
yeah,
nothing I can't
just
manage.
don't want to, have gone up on the infusion rate. I don't want to give him any bolus.
No, I don't blame you. I'm okay with the movement. It's a little bit of movement,
So, I mean, he should settle down. And just
but Luis has got him fully under control. And he's ready to jump on him like a Spaniard riding a...
no, I'm so surprised that he has
Honorable?
No.
zero tolerance for pain, but yes.
Yeah, he has zero tolerance for pain.
No, but he's been having all this pain.
Right.
He doesn't take too much of stuff. If I remember right. Yeah, he doesn't. How would you explain that?
Well, I don't know. People cope with pain different ways. I mean, the most common obviously is behavioral modification.
No, but maybe if he took too much, he wouldn't be able to work.
Yeah, that's a great question. Engineers generally you have to use their brain, and drugs like painkillers dope people up. So,
So
all right.
what about marijuana?
What do I think about marijuana
Pain.
for back pain? I don't have much of an opinion about it.
Mm-hmm.
I don't prescribe it. I don't know. I've heard mixed things about some of the products.
Mm-hmm.
I have to admit, I was brought up to not do drugs,
Mm-hmm.
so I just never did. And
As a last resort or
Huh?
as a last
as a what? A last stop medication? I don't know. I don't think people should live with pain that's fixable. I have a different belief. I think if you can,
No, you're absolutely right.
You can get your pain cured. Why would you want to take drugs the rest of your life, pills to treat it? Just fix it. You know? I mean, unless the cost of fixing it is too much.
So it's
Like,
just the worst also. I mean, it looks like it's really bad.
oh yeah, he's collapsed here. It doesn't matter.
Is this part painful? Or
Oh yeah, it's
Okay.
painful for sure. This is his annulus. This is where the
And
tear and the inflammation are. You can see. We're repairing his annular tear. That's why he's not happy right now with us. I mean, he will be happy.
Mobile, it's fine.
All right, so yeah, this herniation is pretty calcified as well. You can see the calcification is the golden color. And
I need a name, patient name label when you have a chance.
he's not happy right now because we're in the probably one of the more painful discs he has. And we're in the painful part of the painful disc. So,
So the annulus is highly innervated.
the outer annulus is highly innervated, but normally it's not highly innervated. It's the inflammation that makes it highly innervated, right? What happens with granulation tissue, which is the sequela of the initial inflammatory response, is to create granulation tissue, right? It's like the rebuilding phase of the tissue after the inflammation, the initial inflammation. You get leaky capillaries and you get little nerve fibers that are very easy to be set off, right? They're not myelinated and they're very sensitive to pain, painful noxious stimuli. That's why he has so much pain.
You know, he said he had back surgery many years ago. So did that make it worse for him? Or?
I don't know the details of how he did initially after that surgery, standby, but obviously it didn't work for him long term. And the type of surgery he had was just for decompression. It wasn't for back pain. It wasn't for, it was for leg symptoms, right? So laminectomy, microdiscectomy doesn't fix back pain. They only unpinch nerves. And the problem is, there's a big herniation. The problem is that his pinching was from the front of the spine, not the back. And laminectomy is a front of the spine, sorry, a back of the spine technique. And the Duke laser disc repair is a front of the spine decompression technique.
I didn't know that.
I know it's all complicated, but this is, yeah, he's not happy. We're taking the herniation out. He can feel it. He's moving a little bit. Think we're just about ready for that laser again. All right, we're gonna move out again a little bit more, and you can see more of that torn area, the roof. This is the part that's uncomfortable, causing his pain. So after this, I'm having trouble with the fiber. After this, we have one more disc,
Correct. That's
and
the
we'll be
lower,
done.
right? L5, S1?
No, it's 3-4.
Oh, 3, 4, okay.
Yeah, we've already done the left 3-4. Now we're going to do the right 3-4. I don't expect it to take as long because we got most of the herniation out
From the other side.
from the other side.
So you didn't go lower than, you didn't go.
We did 3-4, 4-5, 5-1, all three.
Okay.
But 4-5 was done on the left, 5-1 is being done on the right, because that's where the herniations were that were hitting the nerves. It was a left 4-5 and a right 5-1. So there's no point in doing bilateral 4-5 if you don't need it. 3-4 on the other hand was bilateral herniation.
So Michael, can you help put a strap for his arm, please?
A strap for
He
the
has a
arms?
strap, right? He has a strap.
For the arms?
He has some arms.
Bring
Yeah,
a
he has
strap.
straps, where do you need the strap, Dr. K?
No,
In the arms or
I
where?
don't see it. Yeah, for the wrist.
For the wrist. So outside that door, there's two straps on that bigger stand. Can you bring it in, please?
Lay still. Everything's okay. Just lay still.
I
Thank you.
need arms to be strapped down.
Okay, it's coming.
Almost done with this guy.
Okay. I have to hold it and have come around or something needs to.
And then we're going to come out and we're going to do the last disc. Lay still. Everything's okay. You're doing great. Almost done. So I got basically like a calcified disc here, disc herniation. And it's super hard.
You have to probably come around from that end. You have to come around from that side. Are you able to? No, if you come around that side.
Everything okay, Dr. Kilcarney? Oh, this is just massive amounts of... Poor guy has been dealing with this for a long time. This is the worst of the three so far. 5-1. Definitely really bad. All this is just a mass of scar tissue from years and years of inflammation. Yeah. How are we doing on irrigation? Good?
Well, okay. Good.
Okay. How's he doing from your perspective? I'm fine with his movement. He's got minimal movement. I'm fine with it. You don't need to do anything on my account. Unless his blood pressure is climbing, but I don't see. Now he's starting to move a little bit more than I want him to, but it's at the maximum what I can tolerate. Huh? Blood. Gets cloudy from bleeding. So it's a relatively bloodless, but this patient has a lot of chronic inflammation. And so remember what inflammation that's chronic does is it brings more blood supply to the area of inflammation, right? Plus there's a lot of debris. All this tissue I'm zapping away is pathological. It's chronic inflammatory tissue, scar tissue. It's full of little nerve fibers that are just angry, and that's what I'm fixing, getting rid of this inflammatory tissue. So that's why it has some blood. How's he doing?
Excuse me.
How is he doing?
Doing good.
Good. I'm really asking how you're doing.
Oh, doing great. Thank you.
Well, I'm asking if he's pushing too much.
Yes. Yeah.
Right, he's pushing, but is it too much? Yeah, guys. Just about done. Yes, it's hard to see, folks. I get it. But thank God I've done a couple of these before. And I can see enough of what I need to see to do the surgery. So don't be alarmed. Everything is okay. Alright. So the nerve will be right up there. You can pretty much see the dura, or beginning of the dura, up in the foramen. A little bit of fat at 12 o'clock. And the herniation's pretty much gone. Standby laser, grabber. I'll bring the grabber in so you can see what I'm talking about. When the grabber's in, it's a lot easier. You can see a little vessel that's kind of oozing, little vein. Let's see if I can get a little bit more of that. Beautiful. Take that, laser. So I'm going to try just a little bit more of this medial wall. I think I can get a little more. Let's see if I can get that vein stopped too. All right, any questions from the audience? Just about done with the L5S1 disc.
There are no questions currently.
You have no questions currently, is that what you said?
Yes.
Thank you. Well, I'll give a little plug while we're talking here. Duke Spine Institute has a Facebook page called, Facebook group, I should say, called the Spine Surgery Support Group. And it's a great place for you to go to ask questions and get answers. We post interesting content there. Laser off.
Lights on, please.
And you can go there and get your questions answered by the group. A lot of times I'll answer questions myself just to try to help people out and understand their situation. You meet some interesting people. It's free. There's no charge for the Facebook group. It's called Spine Surgery Support Group. The other thing I'd say is check out the Duke Spine Institute app. The app is full of useful information, descriptions. Get a new one. Lay still.
No, yeah, he's quite asleep, but he
Just lay still. You're doing good. So this is our last disc. This is the fourth position. It's L34 on the right side. And once again, it should be a relatively quick one to fix, but we know it's going to...
any medallions or anything. I'm just doing everything.
Just go ahead and get in with the fluoro. Lay still. Come on up here and help her control the arms. So,
If you have a 2-inch tape,
2-inch tape,
maybe
shot.
2-inch tape, if you're terribly
Okay, very good. So this will be our last disc, as I said, and we got our guide wire in place. We're gonna bring our needle out. Shot. Is that it right there? Good. We'll bring our dilator down over the guide wire. The guide wire guiding the dilator down so we don't injure anything along the way that we shouldn't be injuring. Shot. Shot. Perfect.
Yeah, no, not here. Go around.
You guys doing okay up there?
No, just go around.
You guys doing all right?
Oh, yeah, yeah. Just until you
Shot.
get that thing in.
The tube. Shot.
Yes, sir.
All right, just about done.
So you can't really do these case like this under general at all, right? Or you could.
I could, but it's riskier for the patient.
Jordan, you can go.
From the point of view of you're not able to elicit the response.
Yeah. So it could be done. We've done general anesthesia intubated one time on a patient who was high risk. Out. Yeah. The patient, watch the arm board, watch the suction tubing. The patient was high risk, higher risk for airway. And the anesthesiologist wanted the patient's airway secure throughout the surgery. So I agreed to it and it went perfect. I could probably at my level now do them without the patient being awake, under total general. It just does have a little bit more risk for the patient of having a type of a nerve injury during the surgery, which I don't want for anybody. And I've never had a nerve injury, so I don't want to start now.
So what's the, do you have a BMI limit?
Do I have a BMI limit? No.
You sure?
No. I don't limit people by numbers.
Then you have to put him to sleep.
That's fine. It's really the anesthesiologist. If you came to me and said, there's no way I can do this case safely with them under propofol, I need to do general, then I would look at their anatomy and I would say, you know what, we can do it safely or we can't. And if I felt I could do it safely, we proceed. If I don't feel I can do it safely without them being awake, then we have to cancel the surgery. So, it's really
You have shoulder rolls, right? Those gel rolls to lift the belly up.
We have what do you mean, like for the shoulder
Like
rolls?
rolls
Yeah,
in
we
the-
have those.
in those patients.
what's the problem? Just to get them off their belly?
Yeah. Just
Why
to
don't you
get
just put them on a freaking Jackson table? I've told them already.
Lovely.
Also effective.
What?
It's not good. Every time we do use the Jackson spinal table, we open a set for all the pads
We
and everything.
we what?
We open a set for the spinal.
Oh.
Yeah, so it's
How much are the pads? They're expensive.
I'll say probably $50, $60. So that's why we use it for the fusion.
Yeah.
You could probably try those
I mean, I can
shoulder
create it.
rolls.
Like
If we had to, we could do it. If we really were pinched, we could do it. I need 5 more minutes, maybe 8 more minutes maximum.
Okay. So you couldn't do this in lateral position, right?
No.
No way?
There's doctors that do lateral, but I'm not going to do lateral. You realize I've done 1,000 of these.
No, I'm just thinking about for my own education.
I would say if you had to, we could do it under general.
Okay.
Really? If that makes it better for you.
Oh yeah. But we'll discuss and like you said, that is for you to assess an
Yeah.
army. I wanted to talk to you about this. There is what's called gel seal LMA. So you don't insufflate, there's no cup. So when you put it in, right, this gel seal conforms to the anatomy of the patient, of the orthotics.
Okay.
And some people have been using it for prone procedures. Oh my God, it's very scary.
What is?
Using an LMA for prone.
I know it is risky. I had an anesthesiologist do that once,
Oh my God.
and it was very concerning. Stand by, grabber.
I mean for this type of case?
Yeah.
Oh my God. After?
Yeah, they did.
Oh my God. If you have to turn to like I had to do other day as a rescue.
Yeah.
So this is not so bad, the one you're doing?
This one? It's already it's like 50% done already from
No,
the
to
others.
begin with,
Yeah, yeah.
compared to the other ones.
No, but this was not as bad. Yeah, compared to the other one. But remember, we already went on the other side too.
Oh, you said
Yeah.
that, so sorry, yeah.
No, that's okay. Yeah, we're there's the end right there, so we're very close.
Thank you.
This is all scar tissue from chronic inflammation. Lay still.
Just moving his head.
I'm okay with that. I'm almost done.
I've turned off everything.
5
so you can
minutes.
wake up. Let's see if you can. If it's compatible with what you're doing.
I'm okay right now, but as long as he doesn't come off the table. He's still snoring, so. All right, any questions from our audience?
We do have one from Facebook. One of our viewers is wondering, can you do this surgery if you've already had an epidural steroid injection?
So can this Duke laser disc repair surgery be done on a patient who's already had an epidural steroid injection? The answer is yes. The epidural steroid injection won't have any effect on our ability to do this surgery. It's a fair question. So, just about done. I'm looking lateral here in the foramen. That's where this tear is. And that's where this herniation is. I'm zapping away. Well, the herniation's pretty much gone. About 90%. Just have to clean up a few areas and we're done. So my son and I have been studying European history. And you ask why I'm up until 2 in the morning at night. It's to work on my farm and to work on my farm. Sometimes my children make me feel like I have 2 farms.
Excuse me for one sec, Doc. Hey, Mary, can I have a label, please?
I love them both to death. So Arias is studying European history and he really likes when I read the chapters with him and test him. So we spent a lot of time talking about the French Revolution and the time after the French Revolution, industrial revolutions. Huh? Was that Burgett? Sorry. It was in the early 1800s. Like, I don't remember the exact date. 1815 maybe. 1814. Napoleon. They tried to take over Europe, and then of course the Russians, the Austrians, the Germans, the Prussians. All right, we're done.
You're done?
Yeah, we're done.
No, I want you not to be naughty.
What?
I want you to finish.
I'm done.
Okay.
Yeah, I mean, I'm done. I'm very happy. We got everything done. That's it.
That's important thing.
Yeah.
My job is to make sure.
Yeah, let me just check one more thing. And right there is the epidural space. And the nerve root will be right up here. Well, let me get this right here. This little area. This little nasty thing. That is part of the herniation.
Do you like history?
I like history. I didn't like history when I was in high school. I hated it.
It's okay.
But then now I understand how important history really is. We learn a lot from history about ourselves.
Maybe we were there. We just don't know.
You think so? Different life?
It has to be. Otherwise,
What's amazing to me is that the problems we faced historically hundreds of years ago are the same problems we face today. Energy issues, food issues, agricultural issues, enough food, starvation, poor living conditions, poverty. Why haven't these all been fixed? Even the prison systems,
indiscretions,
corruption,
right?
selfishness, greed. I mean,
Politics,
Yeah.
power.
same story, it's just a few hundred years later.
See, the human mind is not different.
What is it?
Off. I mean, these are off. We're done.
Alright.
Yeah.
We have to have in there some form. Hey, sweetie. Okay.
But, you know, I absolutely hated history in high school because you're forced to study it for a grade. And now I don't have to study it for a grade. I can just enjoy it.
Okay.
Lay still.
Stay still. Dan, it's okay. It's okay.
Lay still.
He's just a little
Yeah, lay still. Everything's okay. All right, folks. We got everything. Lay still. Move your hand. We got everything done. Get the scope off the field.
Hey. Dan, calm down.
All right, you have any questions for me? Lay still. Everything's okay. You're done.
No,
Get
we
it
do
off
not.
the field now.
We should probably
Pull that
put
laser
a bed
fiber.
in the room, please.
Bring the bed. He's going to be ready to flip soon. Luis, you've got to get these covered up.
Jordan, let me.
You have a question for me, Sean?
Disconnect the
No, we do not.
Okay.
Are you gonna choose or?
No, we're done.
Okay.
Yeah. Just lay still. Okay. Come on over here and grab his right hand at the wrist and don't let him pull it down towards his side.
I'm gonna bring this down.
Over here.
Ben, I need you on the other side, please.
And just hold his hand here, sir.
Take his hand and pull it towards you. Don't let him lift himself
Not
up.
quite
Connect the
enough.
camera, please.
Okay, sweetie. It's okay. Good deep breath.
All right, I'm heading over and I can answer some questions for you all. Thank you, Mike.
Everything is good.
I want the bed in here now.
Terrific.
Let's go.
Fixing everything.
All right. I'll be right over there and we'll answer any other questions. So go ahead and start typing them up. Again, I'm Dr. Duke Machen. It's February 4th, 2020. We just finished a very long surgery at 4-level or 4-zone Duke laser disc repair. We did bilateral L3-4. We did right L5-S1 and left L4-5 DLDR. I'm going to call our EBL 5 mil. No complications. Good job. Yeah, we got to get the gurney in. Hope you enjoyed this reality TV uninterrupted live broadcast. I'll be over there to answer questions.
Thank you for joining us again for our second post-op Q&A. We have Dr. Duke in the room with us, ready to answer some questions. Our first viewer from Facebook asks, does calcification return after you've already had surgery, and what causes it?
Okay. Well, thank you for the question. We have one of our viewers asking about calcification and does it return after surgery? What causes it? So let's go ahead and get back to the basics. If you go to medical school and you go to pathology, which is the most important class, one of the most important class, if not the most important class in medical school to understand human diseases, as a matter of fact, pathology is the study of human diseases. It is the class. Pathology encompasses all disease, all things that are abnormal with the human body, or any animal for that matter, or even plants. So when you're talking about plant pathology, coral pathology, human pathology, the field of pathology is the study of disease. It's abnormal conditions, okay? Whether it's a biochemical disease, a genetic disease, an enzyme deficiency, whether it's an organelle problem like a mitochondrial problem, or whether it's a disease of a tissue on a macroscopic level like stroke or inflammation. All diseases go through the field of pathology. And the first thing that you're going to learn, one of the first things you're going to learn in pathology is that abnormal tissue, damaged tissue, gets calcified. And calcification is a process, it's part of inflammation, chronic inflammation, and it's basically where calcium ions, so calcium is a metal ion, or calcium is a metal, and calcium ions are Ca2+, they're divalent cations, they have a 2 charge, and they're basically found throughout your body. Everybody has calcium, it's stored in our bones, and it's released from the bones from time to time to make sure that our blood calcium concentrations remain constant. Calcium is a very important ion in the human body, and almost all of its functions occur as a result of the ion, the ionic form. So it's ionized. It's an ionized metal. And there are things like metalloproteases that use calcium to do their job. And calcium is involved in muscle contractions. Calcium is involved in the release of vesicles that contain neurotransmitters and hormones in the body. So calcium is a very important signal transduction pathway ion. It's very important in many different things in the human body. But one of the things that it does that's weird, that nobody can explain, is it actually binds to damaged tissues. And we call that process dystrophic, D-Y-S-T-R-O-P-H-I-C, dystrophic calcification. So nobody really understands why it happens, but it happens. Obviously, there's an ionic relationship between calcium and the tissue. You want my guess? Here's my guess. What does inflammation do? It brings tremendous amount of blood flow to an area that normally gets very little blood flow. So when you have inflammation in your disc, for example, in the outer part of your disc, the annulus fibrosus, from a herniated disc and a tear, then there's all this inflammation, all this blood flow. Well, you're going to bring a lot more calcium to that area because the calcium is just floating around in the bloodstream going, where should I go? It goes where the blood flow goes. It's kind of like being in a canoe on a river, grade 4 rapids. You're going to go where the water wants you to go. You're not going to go anywhere else. And so the calcium's floating around in this aqueous blood solution throughout your body. It's going to go wherever the blood goes. Well, the blood goes to inflamed areas more. Inflamed areas get more blood flow. And so more calcium is going to end up going to the inflamed area. And I think that's probably the basis of how the calcium gets there. Why it stays there, it probably binds to negatively charged like collagen fibers and elastin fibers, just a negatively charged parts, side chains of proteins that are found in collagen, fibrillary proteins. So, long story short, I know it's highly technical there, but dystrophic calcification isn't so much a disease itself. It's just something that we see, as a result of a process that naturally occurs, like chronic inflammation, occurs naturally. It's not normal, it's just naturally occurring process that causes the calcium to bind to that area and form dystrophic calcification. So that's why we see it in the disc. So the question is, does it return after surgery? No, it doesn't return after surgery. And what causes it? We talked about that. Chronic inflammation. Calcium binds to the tissues, the fibrillary tissues like collagen, elastin, etc., in that area of inflammation. Do we have another question? That was our only question. Only question left. So I'm Dr. R. Duke-Majan. It's February 4, 2020, and looking forward to heading home soon and helping my son with some more homework and perhaps my daughter with some more of her homework. Arias is 15, Ariana is 13, going on 14, and they're both very good students. They take their schoolwork seriously. They both do their homework on their own. They're studying on their own, and by the way, we limit the amount of time they're on phones and other computers. I found that to be very helpful in their development of a sense of responsibility. So for those of you wondering out there, what does Dr. Duke-Majan do with his kids with respect to digital media? Restrict it massively until they can restrict it themselves. And we give it to them only if their grades are straight A's and only if it's the weekend. All right? And we don't give it to them for the whole weekend. We give it to them for a few hours, and then we make them play the piano or the viola or the guitar, or go out for a run or a bike ride, or do some dancing, stretching, whatever. Something that's more natural, other than being on their digital media all the time. Anyway, hope you enjoyed the show, and Sean and I are going to say goodbye, and we look forward to seeing you the next time, which will be next Thursday. Actually, this Thursday we have some surgeries. I think we have a laser surgery on a very special patient, and we also have possibly another surgery, laser or fusion, but we'll have to look at how the schedule develops tomorrow. All right, have a wonderful afternoon. Nice being with you. I'm Dr. R. Duke-Majan, founder and CEO of Duke Spine Institute, signing out.